Japanese encephalitis, JE, the disease and its outcomes, unpredictable and often devastating. Welcome to an educational mini-module series on Japanese encephalitis, or JE. These are intended to take only a few minutes to review. We noted in the module on JE risk that not everyone infected with the JE virus develops JE. In fact, it is a low-incidence disease, but one with considerable consequences. In this module, we will discuss clinical aspects of Japanese encephalitis and disease outcomes. The progression of JE infection to serious disease in humans may be considered in 5 stages. The transmission stage has a 5 to 15-day incubation period that follows infection through a mosquito bite. Most JE infections in humans are asymptomatic, but some people, about 1%, will progress to the prodromal stage, the second stage of disease. These people experience a mild, undifferentiated flu-like illness and have symptoms such as fever, headache, nausea and vomiting, diarrhea, and myalgia. Symptomatic people who consult healthcare providers at this stage are generally not tested or given a specific diagnosis. The acute stage is the onset of acute encephalopathy elicited by JE virus infection of the brain. Patients will have central nervous system manifestations of disease, such as changes in mental status, Parkinsonian syndrome, upper and lower motor neuron paralysis, and seizures. In the late stage of infection, gradual recovery takes place in some, but in others, there are persistent CNS signs and symptoms. The sequelae stage, which is the final stage, describes the health issues that many survivors face: cognitive and memory impairments, psychiatric and behavioral disturbances, neuromuscular dysfunction, impairment of activities of daily living, and seizures, among others. JE outcomes are unpredictable and often devastating. It truly is a disease of high consequence despite its low incidence. Outcomes are death, neurologic impairment that may be catastrophic, and recovery, which may be prolonged. An easy way to remember the clinical consequences of JE is a third, a third, and a third. About 1/3 of patients will die from JE. The literature says this will occur in up to 30% of patients. The next third will be left with serious long-term neurologic, cognitive, and psychiatric impairments. The range of patients left with serious neurologic sequelae is between 30% to 50%. And the last third of patients, about 30%, will recover, although the path to recovery can be prolonged. For more details about the experiences of JE survivors, there are video case studies available to you on PreventJE.com. As an example, here is a case of JE in an 11-year-old American girl of Philippine descent. She traveled with her family to the Philippines for 3 weeks in midsummer. Her family did not seek pre-travel consultation, and she was not vaccinated against JE. She stayed in a screened house outside of Manila, but the family took multiple day trips to coastal and rural areas. She also had a 3-day stay on a modern island resort, where she took evening walks along the beach. During her trip, she received numerous mosquito bites. 6 days after returning to the United States, she was hospitalized with a 2-day history of fever, headache, nausea, vomiting, and neck pain. Signs of infection included a temperature of 103 degrees Fahrenheit and a markedly elevated white blood cell count. In addition, CSF analysis demonstrated white blood cells and an elevated protein level. She was treated empirically for bacterial meningitis. During the evening of her second hospital day, she became somnolent. On the following day, she experienced cardiopulmonary instability and required intubation. Soon after, her pupils became fixed and dilated. An EEG detected no cerebral activity. She subsequently developed a lethal cardiac arrhythmia and died 3 days after admission, 5 days after onset of illness. The diagnosis of JE was not made until post-mortem. A delay in diagnosis of JE is not uncommon. Fortunately, it is unlikely that you will ever be called upon to manage a case of JE, so there are 2 key things to remember about JE management. First, there is no specific treatment. There is no antiviral agent that is effective against JE virus. There is no treatment that is curative. Care is limited to supportive care, which may include heroic efforts such as ICU management, intubation for airway management in the acute setting, and long-term supportive care of life-altering neurologic sequelae. The second key point is, since there is no cure and no specific treatment for JE, preventing JE in the first place is clearly the best protection. In the next mini-module, we will discuss JE prevention. Thanks for listening. Please find additional educational mini-modules about JE and its prevention, along with other resources for clinicians and travelers on www.preventje.com.